As the time has delayed, my slides have also got reduced proportionately. So today, over the next 15 to 20 minutes, what we will do is discuss on basic principles while approaching a child with coma, the common etiologies which we encounter in our clinical practice, emergency stabilization of these kids, key management strategies, and a bit about neurocritical monitoring. So I would like to begin my talk by this quote by William James, who said that everyone knows what consciousness is until one attempts to define it. So consciousness includes two key elements. One is arousal, another one is awareness. Arousal is dependent on reticular activating system and awareness is dependent on the cerebral hemispheres. So coma is an extreme state of unresponsiveness where there is absence of arousal and awareness. Practically, one may take that if these two are absent for more than 1 hour, we should assume that the child may be comatose. Coma occurs when there is an extensive damage of reticular activating system or when there is a diffuse or multifocal bilateral cerebral dysfunction. We need to note that unilateral lesions usually do not cause coma unless there is a secondary compression or compromise of the other hemisphere or reticular activating system. So coma is a relative common medical or sometimes surgical emergency which accounts to about 4.7% over 1 lakh population per year. And even in children less than 16 years, it may increase up to 30 per lakh children in less than 16 years. So it is a common presentation to a pediatric emergency and we are more likely to see such cases. The causes can broadly be classified into two. One, it could be traumatic or it could be non-traumatic. The non-traumatic ones could be infective, hypoxic, ischemic, metabolic, vascular, and rarely malignancy. If we see the traumatic brain injury, the major event which causes damage and triggers everything is the direct injury which occurs, which may be an acceleration injury or a deceleration injury, which commonly occurs during a road traffic accident or during non-accidental trauma as well. In non-traumatic coma, the usual causes can be classified as focal intracranial lesions, which may include vascular lesions like an infarct, bleed, or malformations, or a tumor or abscesses. Sometimes CSF overproduction or obstruction can lead on to hydrocephalus, leading on to raised ICP. And in many cases, generalized brain injury, most commonly in our setting, we see infectious, that is acute meningoencephalitis or a chronic tuberculous meningitis presenting as non-traumatic coma. Other common causes include hypoxic ischemic encephalopathy, osmolar injuries, which we commonly see in DKA, hypernatremic dehydration, and in liver diseases such as Ray's syndrome or hepatic encephalopathy due to any significant fulminant hepatic failure, and metabolic crisis, and finally intoxications. A lot has been discussed by the speakers before me, can all lead to non-traumatic coma. So what is more worrisome is, be it traumatic brain injury, which is a one-time single insult, or a non-traumatic cause, which can be a continuous process. The majority of injury or the manifestation is due to secondary injury, which usually occurs 2 to 3 days post-injury. This leads on to a state of cerebral edema, which eventually culminates in raised ICP. So while managing a patient with raised ICP, we need to remember the age-old Monroe-Kelly doctrine that brain is composed of 3 elements: brain, CSF, and blood. Whenever one component increases, it may compromise the other component. The most important component which we are determined or which we are afraid to compromise is the cerebral perfusion. The cerebral perfusion pressure is given by the formula mean arterial pressure minus intracranial pressure. So whenever the mean arterial blood pressure gets compromised, or when the intracranial pressure gets increased, the cerebral perfusion gets compromised. This leads to decrease in oxygen and nutrients, thus leading on to ischemia and cell death. So the balance is very important, and we need to understand that this cerebral blood flow is mainly determined by some key elements. This may include blood pressure, which is the mean arterial pressure, and PaO2 and PCO2. So the zone of autoregulation occurs at a particular zone when changes in these 3 parameters may not affect the blood flow. However, in extreme conditions, these 3 parameters play a key important role. Not only these factors by their own, but also the duration of these factors also tends to affect the blood flow and the ischemia that the brain suffers. So in an emergency, when such a child presents to us, as discussed by Dr. Balaji in his initial presentation, we need to evaluate, identify, and intervene, and then re-evaluate once we have intervened the patient. So what is more specific about neurological cases who present with coma? We need to quickly remember the neurological ABCDF, which includes neck examination, airway, breathing and circulation, disability, especially dextrose monitoring, exposure wherein we need to check for rashes, bites and bleeding, and electrolytes, especially sodium, and also take a look at the fever and if the child had any seizures. Objectively, we can assess by two scales. One is the AVPU scale, wherein the child may be alert, he may be responsive to verbal stimulus, or he may be responsible or responsive only to painful stimuli, or he may be unresponsive. The more objective method, since AVPU is a rapid but rough method, the more objective method is the GCS scale, which we commonly use, though it is extrapolated from traumatic brain injury. So the three components include eye opening response, verbal response, and motor response, and the maximum score is 15. So based on this scale, whenever a child presents with a GCS of less than 8, or if there is any evidence of herniation, that is unequal pupil, abnormal posturing, or abnormal breathing, or if the child is completely apneic, or in other conditions, whenever the child has any fluid refractory shock or hypoxia, which is not related to neurological, so these are common indications wherein I will intubate upfront and ventilate these children. So we need to follow rapid sequence intubation with caution in order to avoid ICP increase during such procedures. So whenever such cases, especially a child who has suffered road traffic accident comes to us with coma, we should be mindful of the neck injury. Whenever suspected, we need to stabilize the neck first, use a neck collar. If not available, at least use 2 saline bottles and a strap so that the neck is prevented from movement. Use jaw thrust and never try to extend the neck during the time of intubation. Quickly check for correctable factors like hypoglycemia, hypoxia, hypotension, and rhythm disturbances, especially when the child is having extreme tachycardia. If at all any of these is identified, try to intervene. Start a face mask oxygen if the GCS is more than 8. Establish a good IV access. Use fluids and vasopressors if needed, and try to resuscitate these children. After the resuscitation, take a quick sample history with key focus on antecedent symptoms, especially whether there was fever or not. Look at the onset and progression of each symptom, whether there was any medication use, because accidental poisoning, as well described by Dr. Narayanan, it is very common, and also ask for terminal trauma and violent shaking to rule out non-accidental traumas. Also, animal bite is a very important history that we need to take, and always take into consideration local epidemiology and circumstantial history. Vitals can give us many clues like pulse, blood pressure, and temperature, and their variations could point to the diagnosis and the severity of symptoms as well. Also, note that the respiratory rate wise, a child can have tachypnea, which may be related to acidosis or pneumonia, or there can be bradypnea, which can be a sign of brainstem compression. All sorts of abnormal respiratory pattern can be seen in brainstem dysfunction, which can vary from chain stroke breathing, wherein there is a periodic hyperventilation and hyperventilation, and there can be apneusis, ataxics, and in extreme states, the child can present to us with apnea and respiratory arrest. Pupillary examination is the key. Eyes are windows to the brain. So we can see different sizes of pupil and reactivity. What is more concerning to us is that we should be in the watch out for unequal pupil and dilated non-reactive pupil and very small constricted pupil, because these can point to different lesions. And especially if a child is having absent brainstem reflexes, after ruling out neck injury, we need to do a complete doll's eye examination and oculovestibular reflex. As a clinician in the emergency, we need to pick the signs of lateralization, which may include unequal pupil, facial asymmetry, focal seizures, unilateral hypo or hypertonia, asymmetric deep tendon reflexes, and unilateral extensor plantar, which may sort of localize or lateralize a lesion. What is more important is, since herniation syndromes require urgent management, be it whatever type of herniation, we need not understand that this sign is specific for this type of herniation. What we need to understand is that any child who presents with abnormal breathing, any abnormal posturing, be it decorticate or decerebrate, any third nerve palsy, and especially apnea, we need to consider that the child is having herniation syndrome, and we need to aggressively manage this child. As we can see in this picture here, these are the upper one is the decorticate posturing, wherein we can see the flexion of the upper limb and the supination of the arm, and the lower picture shows the decerebrate posturing, wherein there is extension of arm and wrist with pronation. Finally, we need to examine for meningeal indentation, which includes neck rigidity, the Kernick's and Brudzinski sign. But beware that all infants may not demonstrate these signs, and occult meningitis may be present in these children. So having gone through a quick history and examination, we may able to localize or form a provisional diagnosis in our mind if there is absence of localizing or lateralizing feature. It can be any of the severe systemic illness, be it shock, or it could be post-ictal or a non-convulsive status, any metabolic intoxication or a post-infectious cause which can lead on to a diffuse presentation, or it could be a vascular or a bleed, ixol or post-ictal TOTS paralysis if there are any signs of focality in our examination. If there are clinical signs of meningeal irritation, it could be infective process, or sometimes subarachnoid bleed can also present with significant meningeal signs. Once we form a provisional diagnosis in our mind, we investigate with the basic investigations like serum electrolyte, glucose, a blood gas analysis with anion gap, do a complete blood count if infection is suspected, do a renal function test, especially if the child is having oliguria or having disproportionate hypertension on examination, liver function with ammonia, especially hepatic encephalopathy is suspected, do a toxicology screen of blood and urine if any signs of intoxication is suspected, and we can screen for infection based on the local epidemiology. For example, if the clinical symptoms are suspicious of scrub typhus or a malarial infection, or if the child is comes from a local area where these diseases are endemic, we need to screen for such infections upfront. When do we do imaging? So head CT is needed in all conditions of traumatic brain injury, and whenever any structural abnormality such as a bleed, abscess, tumor, or hydrocephalus is suspected. The point to note is a normal CT does not rule out raised ICP. Brain MRI is a useful modality wherein the head CT is non-diagnostic, or if there is a posterior fossa lesion. So where feasible and if the patients are affordable in conditions of non-traumatic coma, we may go in for brain MRI more than CT. But if in your center the CT is available, go for a CT. CSF examination is usually done in whenever the CSF infection is suspected, and it's the gold standard test for proving meningitis. So we do basic CSF studies like protein, glucose, cell count, gram stain, and aerobic culture. Always preserve additional samples depending on the possible etiology. And we have to exert caution in children more than 12 months in whom sutures are starting to close, and especially with GCS less than 12, as fundus examination and head imaging, even if done prior to LB, may not effectively rule out raised ICP, especially when there are features of focality on clinical examination. EEG is as such not a great tool to be used upfront in a case of non-traumatic coma, but as suggested by Dr. Kalaimaran in his talk, any unexplained encephalopathy after the initial evaluation, especially in a status epilepticus setting wherein we are suspecting non-convulsive status epilepticus, we may use. Majority of traumatic brain injury studies have shown that during the initial phase, the EEGs may show non-specific findings in up to 30% of cases, which may resolve spontaneously after 1 month of observation. So in such cases wherein we are suspecting a specific diagnosis such as or a finding such as HSV or SSP, or when non-convulsive status is suspected, we may go ahead and do EEG. And in status epilepticus wherein we are using a medication to control these seizures, or we want to achieve such targets, we may use EEG examination. The management strategies include twofold. One, we have to preserve the cerebral blood flow, and the second is to lower the intracranial pressure. In simple terms, we need to rest the brain. Sorry. Any child presenting with coma should be presumed to have raised ICP. Should I treat all patients with low GCS? A GCS of 12 to 15 needs close observation, and you may start neuroprotective measures. Any child with GCS of 9 to 11, start neuroprotection and osmotherapy as per necessity. And any child with GCS of less than 8, intubate and follow all tires based on the response observed from the child. It is always better to overtreat these children than undertreat them. The neuroprotective bundle, which is commonly suggested, includes simple steps like head end elevation to 30°, midline position, minimal stimulation, adequate pseudoanalgesia, use lidocaines before any plain full procedure or suctioning. Try to maintain euglycemia, try to maintain a normal state, that is euglycemia, euthermia, avoid fever, euvolemia, normoxemia, and normocarbia. Other important components which we can try to manage in our setting are stress ulcer prophylaxis, prevent bed sores, give a good bladder and bowel care, eye care with lubricants and prevent exposure keratitis, and DVT prophylaxis, especially in obese children and those with traumatic injury who require prolonged immobilization. All children who have TBI had to be started on some kind of an anti-epileptic, which is usually given for a period of 7 days to prevent early post-traumatic seizures. But as discussed in our previous lecture, there is no role of prophylactic AED in non-traumatic coma. If the child is found seizing, give benzodiazepines. If whether to give Levipil or phenytoin, there is insufficient recommendation at present to recommend one over other. Give whatever is available at your setting at the earliest. Which drug to use for sedation? Any stimuli, be it agitation, pain, or ventilator asynchrony, can worsen ICP. We need to avoid bolus administrations of midazolam or fentanyl during ICP crisis, as this may cause hypotension and worsen cerebral hypoperfusion. Better to avoid propofol, as it can again cause hypotension during prolonged infusion and metabolic acidosis. The current recommendation says that the choice and dosing of analgesics and sedatives have to be left to the local physician. What we commonly use is a combination of midazolam and fentanyl. Osmotherapy, there are two drugs which we commonly use, mannitol and hypertonic saline. Mannitol has a vast history and experience, easily available. However, it does cause hypotension and worsen acute kidney injury, and longer use may not be helpful, and it has to be given as a bolus and repeated over 4 to 6 hours. Hypertonic saline there is increasing evidence that it performs better than mannitol, a slower and a smoother control of ACP, and many centers have routinely started using hypertonic saline in their management of ICP. So the current consensus states that the mannitol has to be used at doses of 1.25 to 5 ml per kg over 20 minutes. In cases of herniation syndrome or whenever there is an acute elevation of ICP, can be repeated every 4 to 6 hourly. What is suggested for 3% saline is a dose of 2 to 5 ml per kg bolus over 10 to 20 minutes for ICP control, followed by continuous infusion of 0.1 to 1 ml per kg per hour on a sliding scale for 48 to 72 hours with a target sodium of 145 to 155. If you are having a facility to ICP monitor, we titrate these doses to maintain an ICP target of less than 20. There is no role of steroids in traumatic brain injury. However, if you are suspecting intracranial tumors with perilesional edema or acute disseminated encephalomyelitis or TBM or significant neurocystic sarcosis with high lesion load with edema, we can use dexamethasone as the preferred steroid. Acetazolamide, a carbonic anhydrase inhibitor, which decreases CSF production, is primarily used for acute hydrocephalus and in chronic phase also, used in benign intracranial hypertension and high altitude sickness. Any signs for children who presents with herniation pathway, identify by pupillary asymmetry, posturing, bradycardia, apnea or abnormal breathing. If any, hyperventilate them till pupillary signs reverse, give 100% FiO2, give a stat dose of mannitol if not available, hypertonic saline, and try to do a urgent imaging and maybe a CSF drainage or a decompression which may be necessary. Hyperventilation is routinely not recommended. It is usually recommended as a short-term temporizing measure, and aggressive hyperventilation, that is PCO2 of less than 25, should be avoided as it per se causes ischemia. So when to consult a neurosurgeon? Whenever there is a mass lesion such as blood, tumor or abscess that needs removal, any hydrocephalus that needs a CSF diversion procedure, maybe a congenital hydrocephalus or an acquired case such as a tubercular meningitis with hydrocephalus which needs diversion. Whenever you need to place an ICP catheter for monitoring, a decompressive craniectomy, when all first and second tier measures fail, a neurosurgeon needs to be consulted and involved. There are various modalities to monitor ICP in an advanced ICU setting, which is good to know, but many centers do not have all the facility. One important monitoring tool which I will discuss shortly is ICP monitoring. It has been found that use of ICP monitoring in the initial 48 hours has been associated with better survival. Whether to target ICP or CPP, the threshold for ICP is to get it to less than 20. There are various CPP targets which are age-based, and we try to bring up the map so that we try to maintain the cerebral perfusion. And if all the targets cannot be met by maximal use of vasopressors and fluids, it is important to bring down the ICP by using measures such as mannitol or hypertonic saline. So what if our center does not have ICP? So this is the only trial I'll discuss in this presentation. So this is an adult trial which included children more than 13 years of severe traumatic brain injury. And what they did is they had a pressure monitoring group and an imaging clinical group, wherein they did frequent clinical examinations and frequent imaging as per necessity. And their outcome was functional and cognitive status score at the end of 6 months and 6 months mortality. And they found that children who were monitored with ICP at less than or equal to 20 mm of mercury was not found to be superior when intensive care based serial CT scans and clinical examination was conducted. So I would still feel that a center does not have ICP facility. Go with your clinical examination, do appropriate clinical imaging when indicated, consult your surgical colleague whenever there is necessity to drain the and reduce the ICP. The take-home points would be coma is a neurological emergency which requires quick identification of treatable causes